A lot of women don't realize that progesterone changes first, and that can happen around 35 to 40. And then estrogen changes first, wildly fluctuating and then declining. I see irritability kind of across the spectrum, especially related to progesterone. So yeah, hormone therapy, I started at 39. We're getting to a point now, one of the trends I'm seeing is that we're considering hormone therapy a lot sooner.
Right.
We're not waiting until someone is like sleepless for years and struggling with the 100+ symptoms of perimenopause and menopause.
Right.
Thank goodness.
And I think you say 100+. I think people really need to understand how the plethora, the variety of symptoms. I mean, I have a patient who is suffering massive headaches in the hospital getting lumbar punctures. They realized it was her eyes because her cornea was less elastic. It's that key when people start saying, I don't feel like myself, and it happened after 40. Could this possibly be hormone related? Welcome to the Vibrant Wellness Podcast. I'm your host, Dr. Brooke Stubbs, and I am honored today to be joined by Dr. Sara Szal, also formerly known as Sara Gottfried. Dr. Szal is an MIT and Harvard-educated doctor, scientist, and researcher. She combines rigorous training with a deeply human approach to health. She's completed a residency at UCSF and is board certified in OBGYN and integrative medicine. She has over 30 years of clinical experience and has cared for over 25,000 patients, focusing not on just symptom management, but on the root cause healing, deep phenotyping, and personalized therapeutics. She's also the author of 4 New York Times bestselling books on hormones, health, trauma, and longevity. Her clinical domain bridges mental and physical health with a strong interest in N-of-1 trial design, molecular profiling, wearables, and the interface of hormones, metabolism, stress, and aging. Today, she joins us to talk about how not to live just longer, but more vibrantly, exploring the tools and mindset shifts that let us optimize health in our real messy lives. Dr. Szal, it's such a privilege. Thank you for being here today.
Thank you, Dr. Stubbs. Happy to be here.
Oh, good. I can't wait to dive in. Tell us about your journey. How'd you get from OBGYN into what you're doing now?
I had what I think a lot of women experience. I was in my 30s. I had 2 kids, and I just was struggling to have the energy to do it all.
Right.
I was working in medicine. I was seeing 30 to 40 patients a day. And I just, I felt too young to feel so old. And so I went to my primary care doctor and I was like, I can't lose the baby fat. I feel so stressed all of the time. And nothing seems to be working in my body anymore after having these kids. And he wrote on a whiteboard, exercise more plus eat less.
Oh my gosh.
And so that was
a whiteboard.
Right. I mean, so many women are told that. And that got me first, I got this flush of shame. And then I realized, that doesn't feel right. And so I left his office. I went and checked my hormones and my cortisol was 3 times what it should be. And my progesterone was low and I didn't have enough testosterone. And so that got me started to look beyond what I was taught in conventional medicine and to serve women in a different way.
Yeah, we need so much more of that. I have a similar story. I didn't have kids yet, but I go to the doctor feeling sluggish. I love how you call it McMedicine. Same deal. I was in residency at the time. And I said, I just don't feel well. And I'm irritable. I have headaches all the time. I'm so fatigued. And my labs are normal and my vitals are normal. It's like, what are you doing here? You're fine. And of course, nothing to help me with.
Yeah, I like that you're talking about irritability because I think that's such a uniquely female symptom that can happen early, like especially 20s and 30s in women who've got big ambition and they're stressed, especially female physicians.
Right.
So such an important point.
Well, let me talk about that for a second because I have like the best sales pitch for hormone replacement therapy. So I recently started hormone replacement therapy. And for some, it may seem early. I'm 41 years old. And I think, age plays a role, of course, but it's not the only dynamic, right? And I have recently started it and noticed that irritability is just not there. It's insane to me that certain things would set me off. And then I couldn't communicate with my spouse or be grateful for him in the setting of that irritability and all the stress coming my way. For instance, this morning, my whole schedule changed on the drop of a dime. I am having company later, and the company is showing up 4 hours earlier than originally anticipated. For anybody, that would be a stressful event. And I've sat here and I've just accepted it in a way that I haven't been able to do probably for the last 5 years since I had my second child. And I think that's just such a nod to how well these hormones help to regulate those thought processes. And they're obviously estrogens all over the body. So anyway, that's just an anecdotal thing. But I think so many of us women have similar issues.
It's such a great point, because I think a lot of women don't realize that progesterone changes first.
Mm-hmm.
And that can happen around 35 to 40. And then estrogen changes first wildly fluctuating and then declining.
Mm-hmm.
And I see irritability kind of across the spectrum, especially related to progesterone.
Mm-hmm.
So yeah, hormone therapy, I started at 39.
Mm-hmm.
So I think we're getting to a point now, one of the trends I'm seeing is that we're considering hormone therapy a lot sooner.
Right.
We're not waiting until someone is like sleepless for years and struggling with the 100+ symptoms of perimenopause and menopause.
Right.
Thank goodness.
And I think you say 100+. I think people really need to understand how the plethora, the variety of symptoms. I mean, I have a patient who is suffering massive headaches in the hospital getting lumbar punctures. They realized it was her eyes because her cornea was less elastic. Well, it's that key when people start saying, I don't feel like myself, and it happened after 40. Then you say, could this possibly be hormone related? And a lot of times those lab values don't follow what we see symptomatically. Talk to me a little bit about that, how you approach labs in your clinic, how you approach symptoms, and then where that leads your treatment.
I'm a fan of laboratory testing. You know, I was taught to tell women that hormones fluctuate too much. It's not worth it to measure them.
Same. I was taught the same.
But it's ridiculous. Like if you've got a patient who's 34 or 35 and trying to get pregnant, we check every single hormone, right? We
Multiple
look at,
times.
Yeah. Cortisol, progesterone, D3, FSH, and estradiol, anti-Mullerian hormone. We're looking at day 21 progesterone. We're looking at cortisol and insulin, glucose. So why is it that hormones don't fluctuate too much and they're useful if you're trying to get pregnant? But if you're 35, 40, 45 and you're wondering about perimenopause, they're not useful. So I always start with laboratory testing. I think it's important to get the patient's story so that you've got a hypothesis about what could be going on hormonally. And you can come up with a pretty good picture based on where someone is with their menstrual cycle and with other symptoms. And then you confirm it with hormone testing. And I like to do a combination of looking at blood testing because that's the universal language of most conventional physicians, and I like to build bridges with them. But then you also need to look at urine testing and sometimes saliva testing for cortisol.
So is it more testing that you need in order to kind of fill out that picture, or can you get a snapshot and tell a lot? I'm thinking of a case right now where I have a patient she has relatively high estrogen in a perimenopausal state, but all of her symptoms suggest maybe she doesn't have the estrogen balance she needs. So speak to that. Is there something that I'm missing that could help guide me or other providers who might be seeing the same thing on lab values? Is it just estrogen that's the wild one and we really should be looking at progesterone or testosterone? Give me more information.
I think you have to look at the whole constellation.
Okay.
The way I think of it is that it's like a orchestra. And so if you're going to create a beautiful symphony, you need all of these hormones to be working on your side, not working against you. So estrogen can be a little bit tricky because I think of perimenopause as this first phase, which is where progesterone starts to decline, usually because the mitochondria in your eggs are not what they used to be.
Right.
So that's ovarian aging. That's what, for most women, that happens sometime between 35 and 45. So when progesterone starts to decline, it's really easy to pick up that signal. So even a blood test day 21 can be helpful, or day 22, depending on when ovulation occurs. The thing that's a little bit trickier is estradiol, to your point. So estradiol, the primary estrogen that we have in the reproductive years, tends to fluctuate wildly as the control hormones start to change, as you start to run out of right eggs and you start to have ovarian aging. And so sometimes you might catch, especially serum testing, like on a snapshot, you might catch it high or low, depending on the fluctuation.
Sure.
So that's where I think it's important to track over time, to do a time series. And so I also like to look at metabolites, which we can get into.
I can't wait, because that was my next question.
And then testosterone, a lot of women, I see women who are, creating big impact in the world in their 20s and 30s. And if you are not managing your stress and your cortisol well, you can often see initially a period of like high cortisol, high DHEA, maybe high testosterone, and then you burn out over time. So I can see low T in women as young as 28, 29, 30.
Okay, this is low T. This is where the test really gets me, because the normal range hits 0. And so for women to have low T, what is that range? Do you know those numbers off the top of your head? Or is
Yeah,
it
totally.
What are they?
So for women, what I like to see, if we talk about serum, I like to see the result in the top half of the normal range.
Okay.
So that's both total testosterone, free testosterone.
Okay.
We could throw in bioavailable testosterone too. So I don't consider the lower half of the normal range to be very helpful.
Right.
And we know for women, they don't often give you a age-based reference range. So for women, I'm typically, if they say 0 to 45 for total testosterone, I want it to be 22 to 45.
Yeah, same. I tell my patients, you may be in the normal range at 14, but you're going to feel a lot better if we can get you up in the 20, 30s, even 40s.
Most of the time.
Right.
I mean, occasionally I'll see women for whom that's not the case. But I think what's important, if for the people who are listening today, I really love to do baseline testing in women when they're feeling fantastic.
Great.
That's not when they're typically running labs, but for women in their 20s and in their 30s, before they have any problems, like, let's see what your benchmark is with testosterone, DHEA, progesterone, estradiol. Like, let's see where you are, especially based on the menstrual cycle.
And I think a lot of the people who may be listening are providers who are on the continuum of, this is what I was taught, don't check hormones, go with the symptoms, to I'm going to, where you have come to, where I'm going to check early and often. And I might be somewhere in the middle. I'm just getting to that point where, okay, I really see the value. I do want to check early. Now I'm developing this panel around my patients that they get standard when they sign up for, by services, or they come, to get a consultation. How do you approach that? And I also want to talk about metabolites. So I don't know if you want to jump into metabolites and kind of talk about where those fit into that screening process too.
Well, every patient I see, because I do precision medicine, I'm doing a genomic panel. So I'm looking at SNPs related to hormone production.
Right.
And I'm also looking at biomarkers.
Okay.
So I like to do both together in every patient that I see.
Perfect.
So not everyone does that. I mean, if you're someone who's doing more primary care or you're doing functional medicine, you might not want both a genomic panel and also hormone testing. But I find that's valuable in the patients that I'm serving.
Can you give us a case example of where you find the SNPs valuable and what that looks like in relation to the hormone panel?
Yeah. So I'm just thinking of the patients I saw this week.
Perfect.
So I saw a woman who is 44.
Okay.
She's got a family history of Alzheimer's disease. She's got some breast cancer history. And so there's a little bit of between a rock and a hard place, because you want to get the estradiol levels right. And so what we found with her is that she was a poor methylator. So genomic panel looking at cellular functions, methylation was not great.
Okay.
And that's really important for estrogen metabolism, because you got to methylate first before you start thinking about the other ways that you treat the estrogens in your body. So I think about methylation first, and then I think about the so-called good pathway, the bad pathway, and the ugly pathway.
Yes.
So the good pathway is the 2-16, the 2-hydroxy estradiol ratio. Let me say it again. It's the 2-hydroxy pathway. The bad pathway is the 16-hydroxy pathway, and then the so-called ugly pathway, I don't like this language, is the 4-hydroxy pathway, which can be genotoxic and lead to mutations and problems with your DNA. So she had an issue with not making enough of the 2-hydroxy pathway and making too much of the 16-hydroxy pathway. And so we used supplements to try to adjust her, starting first with getting her methylation pathway to work. So mostly adding nutritionally methylators. So that's an example of someone in whom you can optimize the estrogen pathways so that she is possibly able to modulate her risk of breast cancer.
Yeah. And does she feel that? Does she feel that
No,
symptomatically?
It's silent.
Yes.
So unless you're looking at metabolism, you may not know this.
And you can't really see that on anything but this very specific metabolic pathway, this blood test that shows those metabolites.
So it's usually urine testing where we're looking at the metabolites, but yes. I mean, the challenging part is that the last time I looked at the science of metabolism of estrogens, the data, in this case, I'm talking about breast cancer risk. The data is not as strong as I would like it to be. I think we still need to understand, like if someone's got a greater risk of breast cancer, how much do these methylation pathways and the good, bad, and ugly pathways modulate that risk? So we're still in a place where we are collecting more data to understand the outcomes, the clinical outcomes.
And this is just bringing to mind how important it is as a medical provider to be so committed to lifelong learning, because these are not the things we learned in medical school. These are the things that you are finding, that you are committed to seeking out information and research and all of those things. What does that look like for you practically? Because you're running a busy practice, you have a social family life. How do you keep up with the new onset of information that's coming through?
AI.
Yeah.
I mean, it's amazing to me just in the past couple of years how much the synthesis of the literature has changed with the support of AI. So I use a lot of open evidence. I would say I'm probably on there 20, 30 times a day. Just asking questions.
That's great. Yeah.
I mean, I also write books, but I ask questions related to patient care. Yesterday I had a patient who's wondering about blue light blocking glasses.
Sure.
Like, are those helpful after sundown? Are they helpful in women? Is it proven in women versus men, or is all the data in men? She was also wondering about hyperbaric oxygen therapy, HBOT. And so I went on open evidence while I was talking to her on telehealth to parse the data.
Right.
So that's how I mostly keep up that in writing books.
Yeah, I love that. And I think that it's so important to be able to read the evidence. Do you have any pearls for how to look at these things? I mean, I did a whole semester when I was doing my master's on how to read research just to know if the study was good or if it had some power behind it. Do you have any recommendations for when you're reading research paper, how to tell like where the truth is?
It's such a good point because, often research is published with a conflict of interest. So I would say
a little bias.
I would say first, know whether the research is clean or if it's got industry influence.
Funding.
Second is, I would say, hierarchy of evidence. So when I'm looking at data, I would say at the bottom of the hierarchy of evidence is expert opinion. And next up is case series, retrospective studies. Next up is prospective series like the Nurse Cell study. But even there, you can get into trouble like we did with hormone therapy. and then the randomized trial.
Mm-hmm.
But the problem with the randomized trial is it's mostly looking at drugs versus placebo.
Right.
So above all of that, like what I was taught at Harvard Medical School is the N of 1 experiment.
I can't wait to talk about this. I love this idea. Tell us more.
So N of 1 experiments are things that I feel like our patients are doing all the time. They're just not calling it that.
Yeah.
They're trying glycine for sleep, or they're trying blue light blocking glasses to see if it helps them with their HRV, or they've got some other outcome they're looking at.
Mm-hmm.
So it's where you have a person who's got a period of time that's their control period, kind of in the wild, feral, seeing what happens with some particular outcome. Right. I do a lot related to sleep, cognitive function, HRV. And then you do an intervention to see if it makes a difference in the outcome that you're tracking.
I think this is such a good approach because so many times I'll have patients come in my office. I've given them advice and then they go about their busy lives and then they remember, oh yeah, I'm supposed to integrate that. And they maybe do it, but they don't take enough time to really commit to themselves, whether it's worked or not. And then they come back in my office and they're like, oh yeah, I did that. I don't know. It's the N of 1 is, hypothesizing and really making a study design for yourself.
Exactly.
How do you recommend patients record this data? And is it simple? Can they put in a note on their phone? Is it something that you keep track of with them in their chart? Or tell me how you go about that process with your patients.
You have to make it easy.
Okay.
So I think the point you're making is when you're working with really busy people, like they don't have time to track all these things the way that a perfect experiment would be done.
True.
But on the other hand, if you've got someone with an elevated LDL or ApoB and you're trying to determine whether they would benefit from statins, what we know is that the old school way of doing it of here, let's try a statin and see if it helps. Often, depending on the patient population, you have to treat 50, 100, 200 people for one person to benefit. So the idea with this kind of experiment, the way that I get someone engaged with the process is to say, we're going to determine if this is a good intervention for you. So how do you make it easier? I think you set up based on their values, like the top priority for an N of 1 experiment.
Okay.
And then you determine what the outcome is. So if it's LDL or ApoB or LDL fractionation, maybe you set up an intervention like a food plan, and then you plan to measure them again in 3 months. And then you make it as easy as possible. So in that situation, maybe there's an app that can remind them of what foods to be eating each day, what macro targets to be getting to. Maybe they've got a continuous glucose monitor and you're supporting them in that way. So that's one example of how I like to set it up. And then I think what's coming is more dashboards that we can use, virtual dashboards that we share with our patients. Like Guava Health is an example. Heads Up Health is another, where we're tracking things like continuous glucose monitor, HRV, maybe sleep and how restful their night's sleep is. Maybe we're looking at cortisol and other biomarkers, and we're tracking that over time. And then we can add in the intervention and then see if there's a difference. So instead of this kind of vague sense of subjectively, do I feel different on this treatment? It allows you to collect data and then to show it back to the patient. My favorite simple experiment is look at the effect of alcohol on your HRV.
Okay.
So you can track HRV continuously. Someone who's got a Whoop or an Oura Ring or some other tracker. And then you try the tequila experiment. So you have a shot of tequila. Maybe they do it, every night for a week. And you track their HRV before that. And you track it afterwards. And then you show them the data. You're like,
and this is what it's doing.
Yeah, darling, your HRV is half what it is when you're not on tequila.
And when I talk to, so we're on this, and I don't know, you might be on it too, this longevity network WhatsApp. And, hundreds of doctors all texting, wanting information, experts weighing in. I find it to be absolutely fascinating. I learn so much. It's hard to keep up with, of course, but a lot of the conversation on there is what wearables are best and, HRV is a big topic of discussion with the wearables because some people will be really healthy and their HRVs are really low.
Yeah.
And they're not modifying, and they're having trouble modifying them through lifestyle. And so then there's this discussion of are these accurate? And I think one thing that keeps shining through these discussions is you have to wear them consistently for them to really make a difference. Talk to me about that, what you find in your patients, how you kind of go about if they have a low HRV, what the consistency in the data of the wearables is. Do you have any more information about that?
For sure. So I would say I'm agnostic. I'm agnostic about what kind of wearable you need. I would say there's some that outperform others.
Okay.
I would probably put Aura and Whoop at the higher end of the list.
Good to know.
Especially in terms of sleep and HRV data.
Okay.
I've been frankly underwhelmed by Apple Watches.
Okay.
I just find that personally, I've been tracking my HRV for about 15 years.
Okay.
I just find that Apple Watch doesn't give me great data. I also use 8 Sleep. I think that's a great way to track HRV and also sleep. And now it gives you kind of an assessment of whether you've got a sleep debt or you've got, more sleep than you need.
Right.
So I really love those trackers. Those are probably my 3 favorites. And then in terms of experiments and consistency, some people just don't like to wear rings. And so a Whoop might be a better choice for them. For people who are super low maintenance, I would say the 8 Sleep is probably the way to go. So just get a mattress cover and all of these things are tracked for you.
I love it.
And there's a lot of consistency. I mean, I wear all of these things. There's a lot of consistency between the data.
Okay.
So pick one, be consistent.
Okay. I like it. And then when you talk about how to change these factors, HRV is super important. We can focus on that, or we can focus on other wearable data. Tell me about lifestyle factors. Where do you focus your attention? What issues do you see most often in your practice?
Well, I would say with lifestyle factors, it really depends on the person.
Okay.
I mean, I can give you some trends for the populations that I serve.
Sure.
But I serve sort of strange populations. I mostly take care of perimenopausal and menopausal women.
Okay.
I take care of a lot of executives. So I work in the executive health program at Thomas Jefferson University.
Right.
And then I take care of professional athletes.
Awesome.
And they're all different.
Yeah.
Perimenopausal women, they typically have a mean HRV in the 30s.
Okay.
So sort of 33 to 40. And then there's a pretty significant decline that happens in perimenopause with HRV. And there's a lot of reasons for that, probably related to estrogen and also progesterone and sleep. And then it kind of stabilizes in menopause. With professional athletes, they've got the most impressive HRV that I've ever seen in my life. I mean, mostly like in the hundreds and even higher than that. And then executives, it kind of depends on how much they drink. I mean, with executives, it's often, they're managing a lot of stress, kind of high stakes. And so if they're super attentive to inputs and outputs, they're really careful about alcohol, they're protective of their sleep, often their HRV is quite good, especially the younger ones. The ones that really push themselves hard and they skimp on sleep and they use coffee to kind of make up the difference. That's where you start to see a slide with HRV.
Okay. That's really good to know. I think people can really find themselves in one of those buckets and can correlate that with their own lifestyle. So that's really good information. You talk about stress. Tell me how stress affects, maybe not HRV since we talked about that, but other aspects of health and longevity.
Oh, it's critical. I mean, it's involved in 95% of the root cause or exacerbation of chronic disease. And I think one of the things that always impresses me, because I've been wearing a continuous glucose monitor for about 8 years now, is how much the stress response is involved in these other physiological systems. So yes, for sure, HRV, yes, sleep, but also things like what's going on with your gut health? Do you have increased intestinal permeability? Are you someone who's got food intolerances because you've got leaky gut? Are you on the path to autoimmune disease? And we know from the Function Health data set that that's 30% of the healthy people who are getting their blood work done have a positive anti-nuclear antibody. So stress definitely plays a huge role.
Huge.
There's some people who navigate stress and dance with it in a really effective way. And they're able, like my partner is able to do this. He's got multiple black belts. He can deal with stress, like the Buddha. Like he's just really good with it. And I learned from him because I'm not quite as good. Like I need a much bigger spiritual practice to get to kind of the same place that he does with how he manages cortisol. So I think it's good to know about the way that you deal with stress. Definitely run a 4-point cortisol test or 5-point if you're someone who doesn't sleep well, so that you get a sense of what your cortisol load is.
Okay. And do you find that cortisol is always a really good predictor of that stress outcome? Or can you have people kind of within the normal ranges of cortisol and still have some symptoms of stress? How do you deal with that?
Most of my patients have a problem with their cortisol.
They do.
I mean,
really high performing.
I mean, when I see someone who's got like stone cold normal cortisol pattern, like their diurnal pattern, their cortisol awakening response is totally normal. I pay attention because that's probably like 2 to 5% of my population.
And
the rest of people are similar to the way I was in my 30s, which was high cortisol first thing in the morning, get up, like have, some process for how you want to be creative and kind of chase after your dreams. So I see that a lot, especially in creators and entrepreneurs and executives. And then there's people who've got sort of the burnout pattern where they've been driving so hard for so long that they just can't mount a normal cortisol response. So I would say most people have an issue with their cortisol.
Okay. Good information.
Sadly, but yes.
We all got to focus. I think it's the stress of life is so often overlooked in our long-term health. That's why I love everything that's being done in the longevity space and the focus on it. What other lifestyle factors are, really paramount in your patients?
I think connection is critical.
I love it.
Yeah. So, it's now being compared to smoking cigarettes. Like if you are more lonely and you don't have strong social connection, there was some new data that I think just came out in preprint. I mean, we could link to it in the show notes, looking at hasslers.
Okay.
So if you've got people in your life who are supportive some of the time, but they create hassles and difficulty at other times in your life, those people actually rob you of longevity.
Do they?
And so I think it's worthwhile to kind of do an audit on what's going on with the relationships in your life. Meaning and purpose, I think, are so critical. These are sort of softer outcomes to be tracking. But when it comes to longevity, I think hormones are critical.
Yeah,
I pay a lot of attention to that.
Yes, I pay a lot of attention to it now, not only being kind of having gone through that treatment and feeling even just a little bit of relief from a brain fog I didn't even realize I had. I mean, that's so real. That's so tactile when you can go from irritable, not sleeping well, having a little bit of brain fog to like clarity, not irritable.
Totally.
And then you see long-term health benefits, right? So we can talk about all of that, but bone health, brain health, heart health. I wish more women were on board with this, but of course, the WHI did such a disservice to how we administer hormone therapy now.
Yeah. I mean, we need to put the final nail in the coffin of WHI, the Women's Health Initiative.
What would that final nail sound like?
Well, I think we have it, which is it's time for the misinterpretation of this study to end. So what we know is that 100% of women, I would say starting at 35, deserve counseling about hormone therapy. 100%.
Yes.
Not everyone qualifies. Not everyone needs it or wants it, but 100% deserve counseling. The female brain changes very dramatically right around age 40.
Right.
And so the brain fog that you're talking about, feeling like your processing speed is slower, feeling like, wait, where are my keys? Where's my phone?
Where are the words I'm trying to find?
Where's the word I'm trying to find? Like those things can be a sign of what's called cerebral hypometabolism.
Okay.
And so much of that is mediated by estrogen. So even if your serum levels of estrogen are still in the normal range and your follicle stimulating hormone is in the normal range in your blood, there starts to be this subtle change in the way that the female brain uses glucose. And it occurs in 80% of women over the age of 40.
Wow.
So I think this is a really critical point because so many women don't realize that there is this backstory, and it all relates to mitochondria. So mitochondria have these little docks for estradiol. And if you don't have sufficient estradiol or it's fluctuating wildly, you're going to find that your brain energy is fluctuating wildly.
Yeah.
So that brain fog is
That's
a classic
so
symptom.
Talk about the brain and the use of hormones or maybe lack thereof and mental health. You're so big into psychology and mental health and how that changes as we age. Give us a little more information.
Yeah, well, I'm a big fan of hormone therapy as early as possible. So I typically start with progesterone, and women, once they start to have a low progesterone, if they're still trying to get pregnant, then we might use something like chaste-3 to optimize progesterone levels. And then I like to use estrogen therapy. And what we know in terms of mental health effects is that there's for sure a cognitive benefit, but it's a critical window that's less than what we learned from the Women's Health Initiative. So we think for cardiovascular disease, there's this critical window where hormone therapy has benefits and very little risk before age 60. We think the window is about 10 years from menopause, but I would say when it comes to brain health, it's shorter. It's more like 5 years.
Okay.
So I'm a big fan of hormone therapy. When you look at mental health outcomes like anxiety, depression, irritability, I would say hormone therapy is shown in small randomized trials to make a significant difference. So I think hormone therapy, especially transdermal estrogen, should be the first line of treatment in a woman who's 35, 40 with depression or anxiety to see if it helps her.
Yeah. And I do think sometimes we don't mention suicide, but suicide rates go up and have gone up since the WHI study and the lack of hormones being prescribed to women. And I think we're doing a huge disservice by not incorporating that into our mental health treatments.
Huge. I mean, suicide rates are the highest in women 45 to 55. And it's also the time when women have the highest rates of filing for divorce. So we want to be thinking about this.
It's not
how do we support women?
Yeah, it really does affect. And as you say, connection, right? If these rates are high and I'm irritable and I don't have, the tools that I need for my brain to fire and my mitochondria to be working, how will I be able to have those really meaningful, supportive connections in my life? And I think so much of what I was able to do in my early 30s was lifestyle based, and lifestyle can certainly push out some of these perimenopausal symptoms and delay some of the aging of your eggs and, the ovaries. But then 100% of women are going to go into menopause if you live long enough. So when we think about menopause, it's inevitable. And so I think having that open mind to putting back what we've lost as opposed to, this is a huge risk. We're really giving these bioidentical type of things that your body already had in it naturally, but has lost as they age.
That's right. I mean, you just described the key part of my next book, which is about female longevity.
I can't wait.
And how we've got to build the base camp, which is all those lifestyle medicine factors that you were talking about, getting the right sleep, having the right connections, eating the right food that is personal to you, getting the right exercise, zone 2, VO2 max training. And then you have to have that in place for some of these other treatments to be really effective. Like you can't just take someone who doesn't sleep sufficiently and is stressed out of her mind and has isolation and loneliness, give her hormone therapy, maybe some peptides, and hope for the best. Like you will do so much better if you've got that base camp dialed in.
Yeah, I couldn't agree more. I think that's really what I'm looking for in all my patients too. Is there anything we didn't talk about today that you really want people to hear and know?
Well, I would say for clinicians who haven't checked their cortisol, like start with yourself. Like do a hormone panel and see where you are.
Okay.
Because that helps you learn more than just testing your patients. I think you've really got to understand your own inner world and how that maps to your hormonal map.
Right.
I would say that's critical. And then to do a time series so that you're tracking your own hormones over time.
And what does an optimal day in your life look like? Tell me your best wellness day.
Oh my gosh. Okay. Well, I'm here in Austin, Texas with you, and I just flew in late last night from San Francisco. But I got up this morning with my friend Kayla Barnes.
I love Kayla.
And we did like the perfect day already. So we went for a walk within 30 minutes of waking up.
Love it.
So we had, kind of a fast walk, mostly zone 2. It was like 25 minutes of zone 2 together.
Okay.
Connecting, talking. And then we we got our pump in. We did weightlifting she's a beast. She's a total beast.
I've seen her online.
Oh my gosh.
I haven't worked out with her yet, but
yeah, I mean, her dumbbells, I think were about double mine.
Good for her.
But that's okay. So we did our pump, then we got in the sauna, and all of it is like girl time, girl medicine. It's so good for you to have that oxytocin of being with another woman who's like-minded. There's all this data showing that if you're a man and you want to improve your health, be with a woman. And if you're a woman and you want to improve your health, be with your girlfriends. Like single women have much better health outcomes than those of us that, have been married. In any case, there's ways to work around it because I understand you're happily married. So I think that's really critical. And then that's when you get to do your creative work.
Yes.
So I'm having the best day ever today.
It's a beautiful day. Good. I'm so glad. Well, thank you so much for taking time out of your beautiful day to be with us today.
My pleasure.
How can people find you?
The best place is to go to saraszalmd.com.
Okay.
That's the new website. Post-divorce 3 years ago.
Okay. Congrats.
And Instagram, we're still working with Meta to try to change over my handle. So there's, a link to it from the website, saraszalmd.com.
MD. Thank you. Okay. Thank you. And tell us a little bit about your new book coming out.
Oh my gosh, I'm so excited. So it's designed for women 30 plus who want to optimize their hormones. They want, help with how to design these N of 1 experiments to really build their base.
Okay.
And then hormone therapy plus, because I don't think it's just about hormones. I think it's about hormones and biologics and peptides to really optimize the path to longevity. So that's what the book's about.
All right. Well, I hope we get to talk many more times because there's so much more to learn from you. And thank you again for being here. And thank you all for listening. Please follow along the Vibrant Wellness podcast and follow us for more on Instagram at Vibrant Labs.